I'd like to thank Dr. Meenakshi and Dr. Prajna for this opportunity. So I'll be touching on assessment of the surgical skills more, moving on from the clinical aspects on the Oscar practice, and also to see is my trainee surgically competent to step into the outside regular practice. So as we all agree, it's critical to have a well-structured training curriculum in place. The components, as we know, would include having the lectures, make them observe the surgeries, wet lab practice, the actual hands-on on the patients, and the post-op evaluation as well. And we would do this for both our internal trainees, which are residents and fellows, and our junior consultants, and the external trainees as well. So internally, we have trained approximately about 1,200 residents so far since inception at ARAVIND across all our hospitals, and about 1,070 fellows in the anti-segment fellowship programs. And we also have a 1-month-long training program, which Dr. Nachia began in 1993, which is still on. The SICS and FACO is still on. And over these last 32 years, this is happening in all our 6 tertiary centers. Around 3,000 courses have been run, and numerous ophthalmologists from within India and across the globe have benefited from this training program. And we try to replicate, the 1 month, whatever training we give for these external trainees, we do it for our PGs and fellows as well. So we kind of make it a very intense training program the first month when we start the program. When we first had to begin the FACO training course in 2005, we came up with a matrix as to what will be the different components of a training program, looking from the different aspects like pre-surgical training, the surgical training, and the post-surgical aspects. And from the perspective of knowledge, skill, and attitude. Of course, attitude, as we know, is very critical. Example, during surgery, if the trainee feels that they are not sure about how things are going, they have to ask for help. So all of this is told to them right in the beginning. And we also have another 4th aspect of evaluation, which is also very incorporated into the training program. Example, following the surgery, immediately they will have to fill their logbooks, do a surgical review of their videos, see the patients on the post-op with their trainers, and look at different aspects like the rhexis and if any residual cortex and IOL placement, etc. So through the course of the next few slides, I'll just be running through what are the different things we do at ARAVIND in terms of assessing the trainees. So the trainer's role is critical. We normally have a single trainer who stays with them through this entire 1-month program. Before they start their actual surgeries, we have heard from the previous speakers that it's important for them to get as much hands-on as possible in the wet lab. So we do the suturing. So we don't do ECC at ARAVIND anymore. So they do at least 25 sutures every day in the first 15 days. Again, for the different reasons mentioned earlier, this is very critical. And the different aspects like phaco machine connections, foot pedal, all of this as well, we'll have the assessor by them just to see if they're able to get a hold of all these basic concepts before they touch the patient. And the simulators, again, we saw some beautiful talks, and the different hospitals, either we have the Help Me See or the Fidelis for phaco or the Fundamental VR from Orbis for SICS in the different centers. I think it's useful if you can have one of these. The newer ones are more portable. They are comparatively less expensive. And the good thing is we also have assessment score from these simulators, which help the trainee and the trainer know regarding their progress. The actual surgical training, for example, if you're going to start our residents on a surgical training, it's the 4th or the 5th month. And this is the number of surgeries they will have to do in the first month. So we really would like to catch them young. We'd like to put a lot of energy in the initial phase itself. And the trainer will be there, of course, with step surgeries initially, and then moving them on to the complete procedure. In case there is any complication, of course, the case is taken on by the trainer. And if the duration is too long, again, the trainer would take over in the interest of the patient and the final outcome. Now, the ICO Oscar, just like we heard about the OCX for the clinical training, this rubric by ICO is extremely useful to assess the surgical performance. The Oscar stands for Ophthalmology Surgical Competency Assessment Rubric. And I think Carl is here, and Carl, along with a lot of researchers, came together and designed this rubric. I think this was first published in 2011, and it had for ECC and phaco. And subsequently, various other surgeries, I think almost every ophthalmic procedure now has an OSCAR as well. Little after it was published, we began using it, but many of our trainees in ARAVIND do SICS to begin with. So we again approached Carl, and then we worked on the SICS OSCAR as well, and we use it routinely now for all the trainees who undergo surgery, and we find it to be very useful. Just to understand about how this works, in contrast to the OCX, this has 4 different grades, from grade 2 to grade 5, which ranges from novice, beginner, advanced beginner, and competent. Again, there is no expert level because you don't expect a trainee or a resident to be an expert in the initial phase of their training phase. So, and on the left, we have the different steps listed. It's about 19 or 20 steps. And what I like about the OSCAR is in different levels. One is that, when the trainee starts the program, they know what their final goal is to be. They know what they will have to do to be competent. For example, if it's capsulorhexis, they'll have to do it central, circular, without cortex disruption. So this becomes an excellent tool for them to understand what they should aim for, and that journey becomes more well-defined. The second, obviously the more important aspect, is it's a very objective tool. As we know, every trainer, every assessor has a different way of grading, but looking at this, the trainee gets the honest feedback as to where they are as of now. And even if you have a different trainer the next case or the next month, you still have an idea as to how your progress is going. And as I mentioned, the last few are the global indices regarding their tissue handling and other aspects. So it's about 19, 20 steps, and each step would go up to a score of 5. So you could probably have maximum of a score of 100 for phaco OSCAR rubric. And I think what we do is we have a printout of this OSCAR rubric in the operating room, and end of the case, we ask the trainer to then grade them for each of the steps. So this is best done real time. You can also do it later. You can have the video recorded and also have someone do it, but I think that most often gets passed. So wherever possible, we would request them to circle it right then. And if there is time right after, discuss with the trainee as to what could have been better. Why was this a 3 and not a 4? And give them some points for improvement as well. And the other thing we would do is we have this sheet where on the top we have the case number, just to know about how their whole training graph looks like. And for each of these cases, each of the steps, the score is then entered, and then we have a final graph. So this curve gives us an idea as to how their learning curve is. So 2 things. In this previous slide, you will see that if they have any issue with a specific step, like say if it's capsulorhexis, flap, and following through, then they probably need a lot more training in one specific step. Second, overall, how competent are they? Are they ready to now be on their own and perform surgery without any supervision? So all of this we will be able to assess with the OSCAR. So before the OSCAR, we used to use complication rates as the metric, which is still good, but it's a very gross. It's more like, you have a complication, it's like an endpoint. Our whole goal obviously is to prevent or reduce it as much as possible. So like I mentioned, the biggest benefit that it's an objective tool here. Besides the OSCAR, we also use the logbook. So we have the traditional logbook where they would mention at every step what they would do and also give a detailed note. So they kind of know at which step was my incision posterior, how did I manage it, I changed my direction of the knife because it was going too deep. So all of this is also mentioned there. And more recently, we are moving on to a more digital format where they basically make a PowerPoint slide set of each of their cases. They did the first 15, 20 cases and talks about, the critical steps and the slit lamp image as well, pre-op and post-op as well. The idea is also to make it seem like the trainee is being a little more proactive. They take initiative, they take responsibility for their training. So they themselves know how they are progressing. The video is also reviewed end of every day along with the trainers because they are in a more relaxed setting. They are able to discuss things which they cannot see under the microscope. The other thing we use the video is for, like even after they finish their intense 1-month training, we have a review of all the complications which happened the previous week done by the trainee surgeons, which includes our residents and fellows and junior consultants. So this week, this is done every Friday, 5 to 6 p.m. and this becomes a very good learning exercise. Again, not to point a finger, but to objectively say what went wrong. And again, you have more people in the room, so they can learn from each other. And that, I think, is a very healthy discussion, which helps them learn and progress further. And in order to do this, we have a kind of a cost-effective recording system in place. We have the Falcon camera and the AVID media, which are, I think, which will fit into most microscopes, and that's the reason why we're able to do it. So almost all our trainees now record their cases, which goes into our central hard drive, and then they retrieve the videos which they want to see, and then this is shared in the Friday meeting. So aspects like any complication such as this. So here you can see the trainee is going a little too deep, and there's a premature entry. And using these videos, you can actually teach them about how to hold the crescent and the direction of how they have to dip the heel, etc. So the other question which comes to our mind is what is an ideal number of surgeries? So for the question of are they ready to perform on their own, or how many surgeries should a resident do to call them competent, or are they ready to practice on their own? So there are different recommendations. The ACMG, as we know, would say 86. So in the US, all the residency programs, the residents will have to do 86 phaco procedures as part of their norm. We don't have a norm such as that in India. Again, this number of 86 was an indicator of experience. It's not considered for competence. So why 86, I don't know. I don't think we know exactly why that number was chosen. And we have various other papers as well, and which talks about what is the complication rate within the first 80 surgeries, about 5%. That probably is the reason why it was chosen as the cutoff. And it's not just the number of cases, it's also how structured the curriculum is. With every case, are they learning the most significant aspects and how this is taught to them. And in this paper by Rogers, he says that with a structured curriculum, you can almost halve the complication rate. So that is the importance of actually hand-holding them and ensuring they are doing the right thing for every patient at every step. So using the OSCAR, so OSCAR typically in our system, we normally use it for all our residents and fellows for the first 20 cases. So every case we get the OSCAR score. But we just did a thesis, one of our residents did a thesis to understand how can we use OSCAR to derive at the ideal number of cases which they have to perform. And with that, I think they did about 250 cases up to the second year of residency. And with that, we realized that they need to do about 119 surgeries to get an OSCAR score of 80. So a score of 80 is actually quite good. So 75 to 80, I think, is pretty good. And that is the number we would now recommend, that doing 120 SICS is a good number for them to be confident. And this kind of also correlates with our complication rates. So with this paper, we looked at what was the complication rate for every 100 surgeries which the residents were doing. So in the first 100, it was about 4.14%, drops to 2.55 from 100 to 200. And then after 200, it becomes less than 2%. So this 120 case, I think, is a good number for us to consider. Again, considering we have a well-structured curriculum and training program in place. So besides this, we also have our own ARAVIND cataract registry, where all the cataract surgeries operated, we are able to kind of have an online portal to assess the complication rates, visual outcome, and this is something which they will do even later, as they're doing more number of surgeries or as they become a consultant as well. So I think in conclusion, the close monitoring and the regular objective feedback will help the trainees to improve significantly and make them both competent and confident surgeons.